Case study number 2. There's a 4-year-old male with autism who attends full-day kindergarten. He has a history of food refusal and malnutrition, as many of those children do, and he eats a severely limited number of foods, only 4 in his diet. He is pale and mildly anemic. He's sent to the nurse's office to eat in isolation. His parent sends 1 can of Pediasure and other foods daily for nutrition, but most days he refuses all foods and only takes a few sips of his Pediasure. He is easily distracted, often not receptive to learning. He has poor endurance for play and often sits while out on the playground. An IEP meeting was held. The family brought a medical report from the pediatrician sharing gastroschisis and complex medical history outpatient feeding evaluation with documented treatment plan that results in acceptance of oral intake. The family was told, "We don't work on feeding here because it does not affect children academically. My nephew is a picky eater and he's fine, and we can offer 2 Pediasures a day." So what are the issues and next steps for this child? The issue is patient abandonment, negligence, and conflict of interest. The child is not receiving free and appropriate public education, or FAPE, according to the Individuals with Disabilities Education Act, or IDEA. Children cannot be denied adequate nutrition and hydration. Research shows the negative impact of malnutrition on IQ levels, cognitive function, and school achievement, with increased behavioral problems. Next steps may include a referral to treating educational SLP with feeding skill to meet that child's needs, professional preparation of SLP with mentoring and education if needed, an educational SLP working or collaborating with a medical SLP in the family to coordinate treatment plans for generalization of skills to multiple settings to optimize nutrition and hydration. If the school responds that they, quote, don't work on feeding, unquote, it is the responsibility of the school to ensure that students are able to access the curriculum, and this includes receiving proper nutrition and hydration. Parents may choose to work with an advocate. The advocate should be someone who knows the law and can interpret medical records. Remember, we must obtain parental consent to communicate with the medical SLP who is or has treated that child. The key to developing appropriate programming is to understand the child's medical history, their status, and their prognosis. Also understanding what treatment strategies are effective and realistic for that particular child. A discussion around the consequences of not intervening should take place.